as it has been said, I'm a surgical resident from Lisbon, Portugal, from Surgery and Renal Transplantation Department in Hospital Santa Cruz. And today I bring you a rare clinical case of Thyroglossal Duct Cyst Carcinoma with Synchronous Thyroid Papillary Carcinoma, and a brief literature review on the subject. So, okay. When defining a neck mass, we're talking about an abnormal lesion that lies in the cervical area that can be either clinically evident by palpation, by inspection, or even only seen in complementary exams. And when presented with a cervical mass, the differential diagnosis is extremely broad and extensive. So we have to think about both benign and malignant pathologies that go from congenital ones, as it is the example of Thyroglossal Duct Cyst, laryngeal cell, cannula, and so many others, to inflammatory ones, from viral bacterial infections to other conditions such as rheumatological diseases, and even neoplastic ones that can be both benign or malignant, as it is, for example, a lipoma, or a malignant lesion like a lymphoma, carcinoma from the thyroid gland, and many others. So when we're presented with a cervical mass, it's very important, it's paramount that we are familiar with neck anatomy, because this allows us to simplify and to know what better to expect in each region. So knowing this, we can look at the neck and divide it into a far more lateral posterior triangle, which is limited by trapezius muscle posteriorly, sternomastoid muscle anteriorly, and the 1/3 of the clavicle bone inferiorly, and anterior triangle that goes from the sternomastoid muscle posteriorly to the midline anteriorly. This is the one that concerns us most as talking about Thyroglossal duct cyst, but it is of paramount importance to know both. And it's also important to know that within the interior triangle of the neck lies a central compartment that is between the trap muscles and the hyoid bone bilaterally. It is also very important when talking about cervical masses to know the lymphatic drainage of the neck, because when thinking of metastatic disease, this is very important to know and to be aware of areas of interest when we are thinking about the primary tumor. Of course, this is just one step. We also have to look at the patient to do a good anamnesis, to know prior history, family history of neck pathology, personal history of neck irradiation, for example, the timing of onset of the symptoms, as we know, for example, lesions that are of inflammatory and infectious nature tend to occur within days or weeks, and for example, a benign neoplastic lesion is a lesion that can be in place for a long time. So the timing is important. The characteristics of the mass is also very important, because a hard mass that has no mobility at all is highly significant and points towards malignant nature. All of this is of extreme importance when trying to reach the diagnosis of a patient with a cervical mass. Now, focusing more on thyroglossal duct cysts, which is the aim of this case report. So these lesions are the most common congenital cervical masses. They comprise about 7% of midline masses in the adult population. Their malignant transformation is very rare, since this first entity was described by Ventrano in 1911. Only 277 cases were reported to date. So it is rare, and synchronous involvement of the thyroid gland is even rarer. With this in mind, I present you the case of our patient, a female, 20 years old, otherwise healthy young woman. She had only smoking habits and a family prior history of thyroid benign pathology. No other known diseases. She presented to us with a 6-month history of a central cervical mass. On physical examination, she had an anterior superior cervical mass that was of hard but not petrous consistency. It was still mobile with deglutition and tongue protrusion, and she had no other cervical masses, no thyroid was palpable, no cervical ganglia were palpable. When we did blood tests, she had normal function of thyroid and normal calcitonin levels. She then did an ultrasound. She then did a cervical ultrasound that showed that mass she had was adhesion in the near proximity of the thyroglossal duct. It was a lobular mass with almost 4 centimeters, and she had no other lesions seen nearby, and the thyroid had some micronodularity, but without clinical significance. So the next step when in our diagnostic approach was to do a fine needle biopsy on this mass. And this lobular mass turned out to be a papillary thyroid carcinoma. With this finding, we were then suspicious of thyroid again. So because this could be either a metastatic presentation of a thyroid carcinoma or a primary duct pathology, since a remnant of the thyroid tissue might have stayed behind. So to make sure of this, we had to repeat our cervical ultrasonography. And when we repeated the cervical ultrasonography, there was a solid nodular lesion that was made evident on the thyroid gland. This was an ill-defined nodular mass that had a classification of Euthyroids 5, which is highly prone for malignancy. This nodule was then subjected to fine needle aspiration biopsy as well, and this confirmed that we had papillary thyroid carcinoma also. Here I present you the CT scan that our patient did. She did an angio CT that this angiogram allowed to see that she had this cystic mass that was multisepted and that had a solid component with not only spontaneous spontaneously dense, but had contrast enhancement as well, which was suspicious. And this was probably the focal papillary carcinoma that we had on our fine needle biopsy. After this, she repeated also a cervical ultrasonography to make sure there were no cervical suspicious ganglia. When she did this ultrasonography, there were no lateral cervical lymph nodes that were augmented or suspicious. She had only one oversized submandibular lymph node that was then subjected also to fine needle aspiration biopsy. The histology report didn't have enough cellularity for a diagnosis, but still we measured thyroglobulin and it was almost untraceable. And this told us that it was almost impossible for her to have on that ganglia metastatic presentation of her papillary carcinoma. After all this workup done, the next step was to present the patient in a multidisciplinary meeting. We discussed the case and then we proceeded to surgery with cistern procedure plus total thyroidectomy, and no cervical lymph node dissection was performed. In this picture, you can see the images, the photographs from the surgery. On the arrow marks the cystic lesion, the Thyroglossal Duct Cyst from anterior, and then you can see a posterior view. Here you have almost at the end of the cistern procedure. In the first picture on the left, in upper left, you can see the section portion of the hyoid bone that would come out with a surgical specimen. Afterwards, we left a drain in the surgical site, and the postoperative period was without complications. The patient was discharged on the second day of postoperative period, and she was discharged on levothyroxine. Here are the pictures of the surgical specimens. Upwards, you have the Thyroglossal Duct Cyst, and inferiorly, the specimen from the total thyroidectomy that was also performed. The histopathological findings of the surgical specimens showed that, in fact, she had a multifocal papillary carcinoma of the thyroid gland, and also in the Thyroglossal cyst, she had papillary carcinoma with local invasion of the surrounding tissue and the hyoid bone. She was then brought again to a multidisciplinary meeting for discussion, and it was decided for complementary treatment with radioactive iodine. Important things to consider in this case. First, you must know that the Thyroglossal Duct Cyst occurs when there's a failure of closure of the duct from the 8th to the 10th week of gestation. As the thyroid descends to the inferior portion of the neck, it descends through through the Thyroglossal duct. And when there's a failure of closure of this duct, the Thyroglossal cyst may form. The potential for malignant transformation of this kind of lesions is very low. It goes from 0.7 to 1.5%. And if we think there's still a big debate about the etiology of these lesions. Some say they're metastatic presentation of a primary tumor, and others say that in fact they're a primary lesion of the duct that is caused by cells that remnant thyroid cells that stay behind during the thyroid descent. Usually, when there's malignant transformation, the most common histopathological finding is of papillary carcinoma in 80% of the cases. Then mixed papillary follicular carcinoma, and very, very rarely earth cell follicular and anaplastic carcinoma are also present. Medullary carcinoma has never been reported in these cystic lesions. It is also interesting and important to know to decide the approach of a patient and to understand how we treat this pathology, that primary papillary carcinoma of the thyroglossal duct presents very rarely with with metastasis and distant, especially distant metastasis. The presentation with synchronous papillary carcinoma of the thyroglossal duct is of 11 to 33%, and usually it's looked as a multifocal pattern of presentation, with and not so much as true metastatic disease. Even though this is a rare entity, it is very important to be aware of it and to know what kind of treatment is the best in these cases. Surgical treatment is warranted when we think, when we're talking about carcinoma of the thyroglossal duct. And what kind of procedure should be made? Literature shows us that cystic removal alone is associated with up to 50% of the recurrence rate. The introduction later on of Sistrung's procedure dropped this recurrence rate to as low as 3%. And what is Sistrung's procedure? Sistrung's procedure encompasses the removal of the cyst plus the mid portion of the hyoid bone and a portion of tissue around the thyroglossal duct up to the foramen cecum to ensure the entire removal of the lesion. And should this Sistrung procedure be accompanied by total thyroidectomy? Some authors and the authors that consider that this is a metastatic presentation of a primary tumor from, for example, the thyroid gland, they believe that total thyroidectomy should be performed at the same surgery. But what is most important is to stratify, to make a risk stratification of the patient, because in patients with high risk, it is important to do the total thyroidectomy. For example, a patient with a suspicious thyroid nodule, the presence of lymphadenopathy, or the history of neck irradiation. This makes the patient with high risk patient. And in these cases, it's advised to perform a total thyroidectomy at the same surgery. And if we think about it, even if later on, even if, for example, this nodule was not confirmed by biopsy to be a malignant nodule, if it is highly suspicious and it requires a surgery later on, this would be a violated territory, which would make the second surgery much harder. So we've talked about adding total thyroidectomy to Sistrung's procedure. What about a selective cervical lymphadenectomy? Should that be performed as well? As we've seen before, the reported incidence of cervical node metastasis is low in this kind of pathology. So this should not be done routinely. It should only be done if there's suspected lymph node invasion. Even though in literature, some small studies, some small clusters have shown no significance in surgical survival in the patients that did cervical lymphadenectomy and the ones that did not at the first surgery. But these were reports from very small clusters and probably not with significance for a higher population. So we should perform the cervical lymphadenectomy when suspected lymph node pathology. And should we do hormone suppression therapy or ablation with radioactive iodine after the surgery as complementary treatment? The authors that advise for total thyroidectomy always, as they advoke that this is a disease that comes from a metastatic thyroid disease, they advise to do hormone suppression always. Actually, the patient has to start levothyroxine as if they do total thyroidectomy, but they also advise to do radioactive iodine. But for the other authors, which is the most common theory, they see beneficial effect on the suppression of the thyroid stimulus with thyroid stimulating hormone, but probably no need for radioactive iodine. Complementary radioactive iodine therapy should only be done if there is a synchronous thyroid carcinoma or, for example, invasive features in the Thyroglossal Duct Cyst carcinoma. Also, there's the need for a periodical follow-up, which is in this case considered an annual follow-up with ultrasound, or in this case with ultrasound and thyroid function tests. To finish, it is important to know that the prognosis overall of this pathology is still good, and that with adequate surgical treatment, the survival and the cure rate is reported up to 95% if we think of cistron procedure alone. And the extent of surgical procedure was the one outcome of the one predictor of outcome that had significant statistical importance. And this showed a difference from 75 with simple cyst removal, 75% survival at 10 years, to 100% survival with cistron's procedure at 10 years after surgery. Thyroglossal duct cysts are congenital cervical masses that are very common, and so they are important to keep in mind as we're thinking of cervical is mostly anterior cervical masses. Thyroglossal duct cyst carcinoma is a very rare entity that may arise both from metastatic disease or from clusters of thyroid cells within the cysts, this remnant thyroid cells that stay behind. With this in mind, we have to be aware always of the possibility of a synchronous lesion, whether in thyroid, whether in another place. So it is very important to study well the patient, because this will have an impact on what kind of treatment is chosen. So be aware of the extent of local and distant disease. But the main message after all of this is that still it is a disease with a favorable prognosis, and most patients are cured with surgery. Thank you for your time. If you have any questions, I'll be glad to answer them.